I'm back. I promised you that I would be back. Now, listen, if you have this book, this handy dandy little book with everything in it, you already know you have your pharmacology right in this book. So you're going to need to turn towards the back and open up the handout that has the ACE inhibitors on it. If you don't have the $49 book with everything in it, then you're going to need to go get your little pink packet and look at where we're going to be talking about ACE inhibitors. So here's our deal. The number one ACE inhibitor in this country is called lisinopril. ACE inhibitors end in pril. Beta blockers end in OLOL. You know that. That's kindergarten. Let's graduate, shall we? Now, you'll have to really stay with me. This is hard. If you'll remember, we talked about the R.A.A.S was a response to low blood pressure. We said renin, angiotensin, and aldosterone made up the system. We said that spironolactone worked on aldosterone. Now let's talk about ACE inhibitors and how they work on the R.A.A.S system. First of all, you better remember this little part of the drug because it's the ACE that you got to remember. You can't just go around saying ACE inhibitors and not realize that it stands for angiotensin converting enzyme inhibitor. Now you know what that means. That means that it stops the conversion of angiotensin. You know that. So watch this. In number 2, angiotensin was converted to, angiotensin 1 was converted to angiotensin 2. Where did this happen? I made you put stripper glitter on this word. It happened in the lungs. Why do you care? Because a patient on an ACE inhibitor, which ends in pril, specifically lisinopril, and a whole bunch of other kind of drugs, captopril and whatever else, may get that dry cough. They may get that dry cough because these drugs work in the lungs to stop this conversion. Okay, stay with your girl. If the ACE inhibitor stops the conversion of angiotensin 1 into angiotensin 2, and here's where you got to stay with your girl, then would you agree there is no angiotensin 2? Hello, I can't hear you. Valeria, are you with me? Columbus, hello? Where are you, England? I'm looking at you, California. Come on with your girl, Brazil. I am saying to you, if I stop the conversion of A1 into A2, I don't have any A2. By the way, it's such a big deal that you remember what A2 did. Because if I don't have any A2, wow, I don't have any vasoconstriction. So if I don't have any vasoconstriction, the opposite would be vasodilation, which means my blood pressure will drop. Who takes an ACE inhibitor? High blood pressure patients, patients who are hypertensive, or patients who have renal failure. So if I don't have angiotensin 2, then I don't have any vasoconstriction, I don't have any high blood pressure, instead I now have low blood pressure. Okay, stay with me, I ain't nowhere near done. If I don't have any angiotensin 2, then I cannot stimulate the adrenals and I do not get any aldosterone. Oh, wow. If I don't get any aldosterone, then I can't retain salt and I cannot retain water. And if I can't retain salt and water, then I don't have an increased blood volume, and I certainly do not have a high blood pressure. I have a low blood pressure. Woohoo! Because what am I doing? I'm peeing. I don't have any water retention. I'm letting it out. I don't have any sodium retention. I'm letting it out. So, I don't have any vasoconstriction, the opposite of vasodilation. I don't have any fluid retention or even sodium retention. And you know that salt aggravates a blood pressure. It doesn't cause high blood pressure, it just aggravates the hell out of it. Now, it gets better than that. Not only do I not have sodium and water retention, vasoconstriction, I also don't even have to worry about the stimulation of ADH making me reabsorb water, and instead I'm going to get rid of water, and so this whole issue of high blood pressure is going to go down. Okay, I'm almost done. But the hardest part that you've got to remember is what I started with when I started part 1 of the Electrolytes and Fluid lecture. When I started that lecture, I taught you that potassium and sodium are opposites because they're divorced. I taught you that if sodium goes down, potassium goes up, and if potassium goes down, then sodium goes up. And so here we go. If I don't have angiotensin 2, I don't have vasoconstriction. If I don't have angiotensin 2, I don't have aldosterone. If I don't have aldosterone, I don't hold on to my sodium. And if I don't hold on to my sodium, thereby making low sodium in my body, guess what I did? I may retain the K. Oh Lord, watch this. In your medication packet, and again, if you are a nursing student, you don't have any of these materials typically, but if you are an NCLEX review student and you have your medication packet, which says this on the outside, medication categories, what I have written for you inside this lovely little pink deal here is I have written all of your precautions about the ACE inhibitors. I wrote, for example, that they end in pril, that they dilate the blood vessels, that they decrease the blood volume through the R.A.A.S syndrome by blocking the conversion of angio 1 to angio 2 and aldosterone. I put that the #1 side effect is an annoying cough. There it is. I put that you have to watch your potassium level. There is the lisinopril, the #1 ACE inhibitor in the country. This drug is preferred in CHF, diabetes, chronic kidney disease, and with African Americans, even though African Americans have a little bit higher incidence of this life-threatening angioedema. So there you go. Now, I don't know about you, but I'm done. Like, I'm tired of your behind. I'm going to get me some dinner. I'm going to see what my family looks like because I ain't seen them. You need to go study, do some New World questions, some NCLEX 4000 questions, something, and get your life together. Peace out.